Mm. All right, good job. So this week we are going to finish up chapter 17. I will be, excuse me, I will be turning on homework grades shortly as well. So this way you can see where you stand with the class. And then anybody has any questions, wants to meet with me, please feel free to reach out so we can schedule a time to go over your grades. Okay. All right. So the rest of chapter 17, we're going to talk about a little bit about
Okay.
job description, um, what it means, some of the things that you will or can and cannot do as an LPN. And so that'll finish up chapter 17. So I will share my screen. I do have the PowerPoint pulled up. I know you guys have it. So when we look at job descriptions, so LPNs can be charge nurses, especially in a long-term care facility. Generally speaking, as a charge nurse, it does require usually about a minimum of a year's experience. And that really kind of just depends on where you are working. Um, but again, in long-term care, they generally LPNs will serve as a charge nurse. Do have to have licensure, right, in your state of practice. Again, if you plan on traveling, and you get that compact license and you plan on, working in a different state, make sure that you know again what is required under that Nurse Practice Act. um, Collaboration with an interdisciplinary team. You'll assist DONs in new employee orientation. You also will evaluate nursing assistant performance. Okay, so those are some of the things that you're going to do as a charge nurse in a long-term care facility. Um, think about, the other members of that healthcare team, whether it's the activities, dietary, your therapist, your physical, occupational, speech therapists, the social workers, all of those things. When it talk about collaboration with your RNs, you're going to assess, right, evaluate residents' conditions. Let me So you'll have to know the conditions of your residents at all times. You'll assign tasks to nursing assistant team members. So getting to know your CNAs and what their skills and abilities are. You'll also, of course, provide care within your scope of practice according to the healthcare provider's orders. Um, and established standards of care, right, as in your state statutes, as well as administrative policies and procedures of that facility. Recognize symptoms of pending adverse developments and report assisting healthcare providers in diagnostic and therapeutic measures, ensuring proper documentation, giving medications, providing, performing treatments or wound care, um, maintaining accurate and complete records of nursing data collection, um, be efficient in providing or completing your workload, delegating duties, maintaining a safe and hazard-free environment, ensuring privacy, maintaining dignity. So I believe I already know this answer. Um, does anybody plan on working in long-term care when they graduate? Okay, so there's a couple, Teresa and Naya. Are you guys currently CNAs working in long-term care? So you kind of understand what it's like in working in that type of environment. Long-term care is much different than working in a hospital setting, right? In regards, to the number of clients that you will take care of on a daily basis. Other duties, um, observing and reporting symptoms, conditions, and changes, safe medication administration, right? Making sure that you're following those 9 rights of medication administration, that you're gathering data about therapeutic responses, side effects, that we're going back and we're doing follow-ups when you administer like a PRN medication, excuse me, whether it's for blood pressure, whether it's for pain, nausea, all of those, going back and doing your follow-up, um, maintaining your documentation, right? Your vital signs, notifying your providers of any changes in an appropriate manner, and then document those orders received. Communicate with pharmacists on medication needs, maintaining appropriate physical, social, psychological environment, appropriate shift handoff. What's the appropriate way to provide a shift handoff report?
You can do the S bar.
SBAR, absolutely, right? So making sure that the oncoming shift, right, knows any changes, current status of your clients before you leave. What are some tasks that we can assign to nursing assistants?
Getting blood pressure.
Okay.
Maybe assisting with ADLs, daily weights.
Ambulating.
After we
Right.
go over like what they can do, can we go over specific areas where they can't? Because every time I get on a test, I feel like I'll pick taking a blood pressure, and then all of a sudden, like, no, that's the wrong answer. They can't take a blood pressure because the client's post or hypothalamic or not hypothalamic, um, post postural hypotension or something. Like, are there specifics other than like postural hypertension where they wouldn't be able to ambulate or they wouldn't be able to do other things?
So when we look at things that we can delegate and things that we can't delegate to the nursing assistant, it's a lot of, for one, you don't want to delegate to a patient that is not stable, right? So if they're unstable or they have, an acute issue that is going on, then we don't want to delegate. We also don't delegate any, um, what's the word, sterile procedures, right? They have not been, trained on, how to perform those sterile procedures. Trying to think of what else we don't delegate. And then of course, anything that is not within their scope. So remember I said, um, most CNAs, you can assign them to get blood pressures. You can assign them to do anything that is within their scope of practice. What they will not or what they cannot do, because it is when is not within their scope of practice, is to make conclusions. Um, so, they can't, make that decision that the blood pressure is too high, the blood pressure is too low. Um, they are literally just going to perform that task and then report back to the nurse, right? So, they'll bring the blood pressure back to you if it's too low. If it's too high, then of course, you may have to go back and reassess your patient and retake your blood pressure. So they can't evaluate the information that you're having them collect, if that makes sense. You do, if you delegate, know that you're still ultimately responsible for the information that they're providing back to you, right? Making sure that it's accurate. Um, Other things, that you would have to do, is care team and departmental meetings, like most places will have like a stand-up meeting at the beginning of the morning, right, usually around 9, just to give a status update on the residents. Care team meetings, is going to depend on your facility. Like we did ours on Wednesday. So if whoever was due, we would do our care team meetings. Um, and then of course, orienting new team members. So as a charge nurse, as a new nurse comes in, you may be responsible for helping in that orientation process, for that new nurse coming in. So what do you need to know to be in charge, right? So this is always a big one. Um, so we look at it, you have to know the facility organization, right? And those legal aspects about your facility, their mission statement, the organizational chart. Have you guys ever seen an organizational chart? Nobody's seen an org chart? All right, so let me see if I can find an example of an organizational chart to kind of show you. So organizational charts, let's see. I might just be able to find an example chart example. Ooh. um, I like this. This one works. Let me stop sharing. So this is what, and it's kind of varies. I mean, they're gonna, um, vary according to this one, of course, is going to look pretty because it's just a sample. But an org chart kind of just tells you where you fall in the organization. So like this one is, I don't know, maybe an education, I guess it looks like. So like here's your dean, right? You have some ancillary staff, and then they usually have overarching, right? Whoever the boss is, right? Whether it's the CEO or whoever is going to have that overarching, and then it's going to break it down. So like these would be department heads, and then underneath each department, right, there's going to be another, and then a list of people underneath that. So like it's like I said, it's just gonna show you, there's different ones that you may see. These are just templates that are, it's not gonna show me. So, just kind of, again, you may see different ones, like here's your chief executive officer, and then it breaks it down, and then who reports to who. Organizational charts are important. For one, it kind of shows you, who's in charge, who reports to who, so that there's that chain of command that is there. Other things you need to know is what your state statutes are for any licensed personnel on the team. So, for you as an LPN, right, knowing what the nurse or the Nurse Practice Act says for your CNAs, what they can and cannot do in your state of practice. There's also skills checklists for all licensed persons. So, how you guys go to lab, right? And you learn all your skills in lab, and get checked off prior to going to clinical. When you start working, there will be skills checkoffs that you will need to complete on a yearly basis. It's just to make sure that you can and still, know how to perform skills, whether it's inserting a Foley catheter, trach care, trach suctioning, blood draws, IV administration. For CNAs, it would be, your bed baths, your ADL care, your oral care, right? How to use the Hoyer lifts, making sure that they're being used appropriately. So there's going to be skills checklists that must be done. Most places will offer some sort of a skills fair. And during that skills fair, you perform your skills. If you need additional assistance with skills, most organizations have an educator on staff that can assist you with, practicing your skills or learning a new skill. Also, there's skills checklists for cross-trained personnel. You also need to know your job description as well as the job description of your CNAs, right? What falls in your job description, what falls into the RN's job description. And again, what's the job description of those CNAs and other, unlicensed assisted personnel. As far as regulations go, inspection protocols and standards. So working in a facility, even if it is working in a hospital, right? There are periodic inspections that will occur within your time of working, whether it's state, whether it's OSHA, whether it's an accrediting body like Joint Commission. There's another one called, what is it called? DNV is another one. You also have to know the regulations for CMS, which is the Centers for Medicare and Medicaid Services, the National Client Safety Standards, and then other accreditation standards. Not every nursing home has an accrediting body, so things like Joint Commission. Joint Commission is an additional accreditation that anytime you have an additional accreditor, it does cost the facility money to have that accreditation. It's like a gold standard, right? But not all long-term care facilities will have an additional accreditation. They just may have they just may fall under the CMS or, the state Department of Health and Human Services. So like one of the companies that I worked at, we had 9 facilities. And only one facility was actually Joint Commission accredited. The rest of them, because it did cost money to be accredited, they chose to just take one facility and accredit that facility. They held all the other facilities to the same standard, but they only paid to have one of the facilities accredited. What else? The personal policies. So employee handbook, just like your student handbook for school, right? Oh, I forgot to start sharing my screen again. I'm sorry. So you do need to know what the employee manual has. There's lots of information even in your student handbook, right? Just like there would be in an employee handbook. Timesheets, how are the timesheets kept? Is there a manual clock? Payroll policies, taking time off to, leave of absence, do you have PTO time? Do you have sick time? How often, when can you use it? How do you go ahead and to request those days off? Communication reporting, how much time do you have to give them, when you call out sick, right? Usually in most cases, it's at least 2 hours, right? That gives them a little bit of time to try to call somebody in. Meal and coffee break rules, the smoking policy at the facility, the personal device policy that includes, the use of the facility telephones, other electronic devices. The uniform regulations is also a big one. And then, of course, any regulations for using computer-related systems. A lot of places, well, I'm going to say most places have a cell phone policy that is in place, especially regarding recording, right? Or FaceTiming. You don't want to violate HIPAA. Other, routines for each of the shifts, days, nights, weekends, evenings. Generally speaking, each shift has certain responsibilities that must be done, that are shift related. So like I know I just use as an example on Sunday nights on the overnight shift. That's when we change out, the Foley bags and the oxygen tubing, the nebulizer tubing, right? All of that, making sure everything is fresh for the next week. Methods of reporting. So long-term care, because of the regulations, within CMS. Let's just put it this way, and I never thought about this until somebody had mentioned it to me. This was a long time ago. But long-term care is the second most regulated organization in the United States under the nuclear, like power plants and stuff like that. So anybody working in long-term care, like Naya, you understand, very heavily regulated, okay? So for example, if there was a patient that fell and had an injury in a long-term care facility, you only have like 2 hours to report that to Department of Health and Human Services. It is it's very quick turnaround. So things have to be reported within a timely manner, or there is penalties and the facility could get in trouble if they don't. So understanding the reporting methods. Procedure manuals. I thought this was interesting as well. They made a big shift, and I don't know about, where you guys are working in long-term care. But that big skills book that you get as part of your reference package that, lists out all the skills like, inserting a Foley catheter, your blood draws, all of your head to toe assessment. A lot of places use those, right, as their procedure manual. So if you need to, get a urine specimen, if you have to draw blood, or you insert a Foley catheter, then you're going to use that same. A lot of them just have those books literally on the units. How to access the nursing care plan. What is your role in, updating that nursing care plan? How to use the Pyxis, the cardiac systems. So in long-term care, we actually do have Pyxis. Most medications, we use a medication cart. Okay, so if anybody's seen a big old med cart, everybody's meds are on that med cart, and the nurse literally rolls it down the hallway and passes their medication. In long-term care, the Pyxis or Omnicell or another type of medication distribution system is there for emergency medications, right? So let's say, patient comes in and they're a new admission, they have an order for pain medicine, it hasn't come from the pharmacy yet, right? Then we have the ability to pull it from that Pyxis. And there's other medications in there too that may not be readily available because either it's a new order or, there's been a change in the resident's condition and we need to access different medications. What medications are kept on hand is going to be determined by the facility. Care conferences. So care conferences, like I said, these are like your care plan meetings. Most care plan meetings are at least once every 3 months. And you'll meet as a team. So nurses, dietary activities, if they're taking any type of therapy, PTOT speech, um, and the family and the patient or the client will all meet together and discuss the plan of care, go over medications, go over treatments, and kind of just give a general picture of how things are going. And that is for all residents in a long-term care facility, whether they are there for long-term or whether they are there if it's just like, if they have a rehab part of their facility. But these care conferences are mandatory that they hold them. Transcription service. This is how we transcribe healthcare orders or the provider's orders. Um, Most of the time, it's gotten a lot better with some of the long-term care facilities. The providers are in the facilities a lot more often. I know when I first started in long-term care a long time ago, the providers would maybe come in once a month if you were lucky. Now a lot of them have a nurse practitioner or one or two nurse practitioners that work with them. And they may be in the facilities 3 or 4 times a week, right? Looking at the residents. And then, of course, they're accessible to nursing staff, right? Should there be any concerns. And then clinical references. So clinical reference and reference books, those are there to assist you. Should a patient, it's kind of like having a med surg book on hand. Patient comes in with a diagnosis that maybe you're not super familiar with, you can look that up. Or if, patient or client starts asking questions about a disease process and you're not 100% sure, or you just want to go back and do a refresher, there are reference books that are available to you. There also should be, you'll have some sort of access to drug reference as well, whether it's a drug handbook or even using it through the EMR system. Unit administration and processes. What is the admission, the discharge, and the transfer process for your residents in a long-term care, right? What are the requirements for, when they come in as a new resident into the facility? What, assessments need to be done? What paperwork needs to be completed when they're discharged? If they're discharged to home, or if they're discharged to another facility, what is that process, right? Do you send meds home with them? Do you not send meds home with them? Do you call the medications to the pharmacy, right? What is that process? And then if they have to transfer, what if you have to send a resident to an acute care hospital? What is the process for that? Valuables, inventory, and care. So anytime a resident is admitted to a long-term care facility, then there needs to be an inventory of everything that they bring into the facility. All right. All of their, we always recommend that valuables be taken home, right? It's just safer for them to be at home rather than in the facility, because unfortunately theft does occur, no matter what facility that you're in. Things within a long-term care facility that would be different from in a hospital. Who's going to do their laundry, right? Is family going to come and pick up their clothes and wash their clothes, or is the facility going to be the one washing the residents' clothes? So these are things that need to be, asked of when people are admitted into the facilities. And maintaining that list is important. So you do the initial list when they come into the facility, and then if more things are brought to the facility for the resident, then those should be added to their personal property list, right? So that there is, and if things are sent home, same thing, they should be taken off the list. What is the procedure for caring for seriously ill residents? So most places, right? there's a lot of rules and regulations, right, between the Center for Medicare and Medicaid Services, the Department of Health and Human Services. The goal is to try to treat them in place, right? We don't want to have residents that are, going to the hospital, coming back, and then going back to the hospital and having this revolving door. So what is the care for that patient? What if they, what happens when they pass away? What are the procedures for, that death, or should death occur? How do we, provide most post-mortem care for that patient? What are the policies and procedures in place? Autopsy preparation, forms for, any authorizations for procedures. So, generally speaking, they're going to sign a consent when they come into the facility. But then other invasive procedures will require additional consents for those procedures as well. If they are sent out to a hospital, say they have to go have a procedure done at a hospital, then of course those consents will be done at the hospital. What are the visiting hours? So most visiting hours, they may be from 10 in the morning till 8 o'clock at night, or 9 in the morning till 8 o'clock at night. But generally speaking, when we look at long-term care facilities, that is those residents' homes, right? And we are to treat them like their homes. So generally family will be allowed or permitted in any time. Notary publics, if there a notary service in case we have to, witness something, is there a notary service within that facility? Then, of course, our safety. Safety policies are going to be key in order to keeping residents safe in a long-term care facility. Side rails. Do residents have side rails in long-term care?
They do, but is it a safety restraint? If they're up,
So most, so it's a very fine line. So side rails are considered a restraint. Okay. So generally speaking, the side rails, most patients or most residents in long-term care facilities will not have side rails. They were pulled back in 2017, 2018. In order for them to have any kind of side rail, they have to be able to use the side rail. So for positioning or something along those lines, you can't just have a side rail to have a side rail anymore, to keep them from falling out of the bed. So you'll notice that sometimes they'll have the little 1/4 inch side rails at the head of the bed. Those are, the patient needs to be able to use those for positioning. So long story short, just to give a little bit of background, they did a study, and I was working in education and long-term care at the time. This is why I remember this so well. Um, there was some kind of a report that came out that of the millions of people in long-term care facilities in the United States, 3 people had died because they had gotten stuck in their side rails. So when they first came out, they actually had this whole measuring device, because what happens is their head would get stuck between the side rail and the mattress. So they literally had a measuring device about the size of a human head. All right. And if that device could fit between the mattress and the side rail, then it had to be fixed. So the facilities that I was working for at the time, we literally went and we had changed out all the mattresses to make sure that the mattresses fit snugly with those side rails. Then they came around, basically said no more side rails, unless it was for positioning. So we have those, those little quarter length side rails at the head of the bed that people, if they could reach up to grab to pull themselves up in bed or to help them, move around in bed, then that was okay. In the hospital, it's different. There are still side rails in the hospital for safety. But just know that there is a significant difference between care received in a hospital and care received in a long-term care facility. Chair and bed alarms. Generally speaking, we don't use chair and bed alarms anymore in long-term care. Those are also considered a restraint. You can use bed alarms while in the hospital. We have there's a new like monitoring system now that is in place. It's motion detected. So if you have a patient that you worry about them getting out of bed unassisted, it's motion detected. It looks like a camera, but it's not recording anything. It's just sensing motion. And so if they try to get up out of bed, it will say, stop, help is on the way. And so that's supposed to deter them from getting out of bed. It also alerts at the nurse's station that the resident is trying to get out of bed. And there's like a panel that kind of it just tells you what room number it is. And it lights red, yellow, or green. So red, like we're getting up, and green, they're doing good. And we also don't use restraints in long-term care. There is absolutely no restraints, whether it's chemical or physical restraints. So no wrist restraints, vest restraints. I don't know if anybody has ever seen a vest restraint. It literally looks like a vest. It was something that we would use, again, a long time ago, in long-term care. I'm gonna see, if I can find a picture. So I'll stop sharing and I'll show you what a vest restraint looks like. So these were the vest restraints that we would use, keep somebody in bed, and even in some cases, when they're sitting in their wheelchair, if they were, at risk for like leaning forward, falling out of the chair. The reason why we stopped using the vest restraints is because if they were not put on appropriately, and even if they were put on appropriately, they could slide up, and they actually had people that were choked, because it had slid, is that the right word? It had slid up and literally had choked the patient. So again, long-term care, we don't use any type of restraints. Again, whether it's chemical or a physical restraint. And this is gonna probably sound crazy, but residents have the right to fall. All right, so that we can't prevent them from moving around. It's the same thing. Like I said, been in long-term care a long time. It's just my favorite area of nursing to work in. We can't even use Jerry loungers anymore. So I don't know if anybody knows what a Jerry lounger is, but it looked like a big reclining chair, on wheels. We can't even use those anymore because they are considered a restraint as well. Just like, trays in front of wheelchairs, those are considered a restraint unless they're actually eating a meal. So oxygen use, generally there's no smoking in any healthcare facility. Oxygen is stored usually in a separate area. Patient transfer, patient transports, how are they transported within the facility? Unless they're ambulatory, generally speaking, we transport them by wheelchair. If you're transporting by wheelchair, they need to have leg rests on them. and you know you never pull a wheelchair backwards, you always push a wheelchair forward. Um, Body mechanics and back safety. So the number one injury in nurses, right, is back pain. Generally it's from all the turning and twisting and moving that we do. So making sure that we are following proper body mechanics when we're working with our patients to prevent injuries. Now, door alarms are still a thing, okay? They also still have wander alerts for those residents that could potentially leave the facility because they are up walking around. It's just a little bracelet that we put on them that if they start getting towards a door, the doors will automatically lock and an alarm will sound. Down here, the facilities, they have their doors locked 24/7, so there is a code to get in. So residents generally can't get out the door because they don't know the code. Um, so don't have as much of an issue with that. Um, and then of course your standard precautions, your, security, your smoking policy, all of those policies, can the residents go out and smoke? Or, is it in, completely non-smoking facility? So I did work at a facility, in Virginia where the facility was a non-smoking facility, but the residents had been in the facility for so long, they were grandfathered in and they were smokers. They were allowed to go outside and smoke by themselves, but they had to wear a smoking vest. All right, so they had to stop at the nurse's station. They had to, get the smoking vest. They had to get their cigarettes and their lighter out of a lockbox before that they could go outside to smoke. And the smoking vest, it looks like a lead vest too. It's not as heavy as a lead vest, but it looks like a vest that you would put in to get an X-ray. And so if they were outside smoking and inadvertently like dropped ashes on themselves or dropped a cigarette, that it wasn't going to burn them. Equipment, we talked about oxygen. We also, the suction equipment, how to use the beds. I know that sounds crazy, but some of these beds, there's so many different types of beds out there that they can do a lot of different things. Um, is it automatic bed, right? Do you have the little remote? And then of course we have to teach our patients, our clients how to use the remote. Um, do they have any other types of beds within the facilities? Like some of the beds in the hospitals are so cool, like they literally go from laying flat to almost being in a chair position. So it's like super cool. Um, and then of course, respiratory equipment, supplies, respiratory equipment in long-term care is usually going to be like a nebulizer, your oxygen delivery systems, suction equipment, and then food and dietary services, how to, when a resident comes in, how to request their trays, what diet that they are on, what to do if a resident's diet changes. So maybe they came in and they were, great, they were eating regular meals, but then they declined, right? Maybe now they're having a little bit more difficulty swallowing. How do we change their diet from a regular diet to mechanical soft diet, that kind of thing? What is the process for tray service? Where is the stock items for, floor stock items or even for snacks? Do they have those special diets like the low sodium, the diabetic diet? What are the feeding policies? So in long-term care, um, if you have roommates, all right, so say you have two people in a room, one's a feeder and one's not a feeder. They both have to receive their tray. If they're eating in their rooms, they have to receive their trays at the same time. Because it's a dignity issue if they do not. Um, what are the dining room processes, the policies for the dining room? Is there a family tray procedure? So if family wants to come in and eat with the resident, what is the process for requesting a tray for the family member? And then the nursing, care procedures, assisting providers. So morning and evening care, that's usually our ADLs, right? Getting them up and dressed in the excuse me, and then putting them to bed. What is the bathing, showering, bed bath policy? Most long-term care most long-term care facilities offer at least twice a week showers. If the patient is not ambulatory, right? So bring them into the shower room at least twice a week. Making sure that oral care is being done, how to make a bed, right? How to take the vital signs, right? Do you have the equipment to take the vital signs? Is there a blood pressure machine? Or, is it a manual policy, taking them manually? Catheterization, enemas, rectal suppositories, how to record INOs, how to collect the specimens, who collects the specimens. A lot of facilities will have some sort of a lab service that comes in and draws routine labs. And in some cases, if there's a stat lab that needs to be done, you can call the lab service and they will come and draw a stat. But for like urine, stool collection, that generally will be the responsibility of the facility to collect and store until lab gets there. Then where do you store those, right? We talked about recording INOs. Colostomy care. Anybody get to do colostomy care yet? Yeah.
I did yesterday
How was
at
it?
clinical.
How
The
was it?
bag busted.
Oh,
It
that's
was
always
crazy.
fun.
Yeah.
I had one the other night he's had a colostomy for a long time. And he called me in the room, and when I tell you he was covered head to toe, he was like, I don't know what happened. And I went, I don't either. And so he's like, I went and I really don't know what happened. He said he changed the wafer himself, which that could have been part of the problem. But literally it was everywhere, like head to toe, all over his bed. So we get him cleaned up, put it on, don't worry about it. And then not even like 2 hours later, he calls me back in and it did it again. It was a colostomy nightmare. It was like all night was with this. So, because what happened with the way his colostomy was and his surgical scar, can't even say the word, it didn't allow the adhesive on the wafer to stick all the way. And so literally when he had a bowel movement, it started leaking out that way. So once we figured out that was the issue, we got some colostomy paste, put it in there, and it was good to go. But yes, colostomies can be an interesting process. Remember that, depending on where the ostomy is too, is going to determine the consistency of the stool. So like if you have like an ileostomy that's up there in the small intestine, it's going to be more of a liquid stool. If you look at colostomies that are located within the colon, they have a little bit more control over their bowel movements. So it's a little bit different. But yeah, colostomies are so much fun.
Yeah. Hers, she didn't have a stoma. It was just kind of like, I guess she said that the stoma got necrotic, and so they went in and surgically like removed the stoma. So it was just kind of like an opening
Wow.
Yeah.
I've never seen that. That's interesting.
But luckily it wasn't a lot. Like it didn't take us long to clean her up, but
Oh yeah,
yeah,
we had to do a whole
it was
bath in the
crazy.
middle of the night. Yeah. Tons of fun. But yeah, like I said, it can be interesting. I have never seen that. So now I'm gonna have to research that because I have never, so I've always seen a stoma. Like I've never
Yeah,
not
it
seen a
was interesting.
stoma.
I never saw that either, but
Hmm. Interesting. I'm gonna have to look that up. But how to do our glucose monitoring, right? How to use the glucometer. Everywhere you go, it seems like they have a different glucometer that you have to try to figure out how to use, right? And then of course, then you have to make sure that they're calibrated every night. um, NG tubes and gastrostomy tubes. So I will be honest, we don't do a whole lot of NG tubes in long-term care. It really kind of just depends on where you are. One time that we would do an NG tube is if they weren't eating, and they were going out for a G tube placement or a gastrostomy tube placement, we would put an NG tube in so that we could feed them, until they could go get their G tube inserted. Has anybody ever seen a G tube insertion? No, it's actually super cool. Um, so, of course, technology has improved over the years. Initially, like when I first started nursing, it was like a whole big process. They had to get pre-op testing, right? It was, they went to the hospital, they were in the hospital for 2 days, got their tube placed and all that stuff. Actually, when I was doing my RN clinicals, I know forever ago, we were in the ICU and not a resident, but a patient in the ICU needed to have a G2 placement. They did it bedside. This was the coolest thing ever. So the patient is literally in the ICU room. They bring up, I want to say it was I want to say it was X-ray. It was an X-ray machine, a portable X-ray machine. They sedated the patient. They did an endoscopy. So they did like an upper GI. So they put the scope down their throat. They looked around in the stomach. The provider, looked at where he wanted to put the tube. He fed the tube down the scope and popped it out the stomach. And the longest part of the whole procedure was the provider determining where he was going to stick the tube out. It was the coolest thing ever. And I was like, this is really neat. But we also know, what do we do with the G tube once we have it, right? So how do you making sure that you are checking placement, that's going to be determined, generally speaking, the litmus paper is the best way to determine placement. We also need to check residuals, making sure that it gets flushed. How do you give meds through that and through the G tube or the NG tube? And then, of course, the feedings. Medications, right? What equipment is there? Again, long-term care, most of the time they have the big med carts, right? Everybody's meds are in the med cart. Unless it, needs to be refrigerated, then that is kept in a separate med room. Like I said, they may also have some sort of a Pyxis or something in there. What to do when the medication or when the patient needs new medications, how to order them from the pharmacy. And do you know if there's any calculations that you may have to do? What to do in the event that there is a medication error, as far as reporting and completing your incident reports. The narcotics count. So narcotics have to be counted every shift. So every ongoing and offgoing nurse must count the narcotics. And then documentation, how we document. So I forget what year this was, but big overhaul with CMS required everybody to go to EMR, including long-term care. So we did the wonderful switch from paper to EMR. There's always going to be a paper charting system in place in the event of power outages, networks going down. What flow sheets are there? So neuro checks, INOs, that kind of thing. Um, Incident reports. Remember, we don't ever document an incident report in a client's chart, right? That is an internal document that we use. And then are there any special lists, right? Wanderers, hearing aids, sometimes we'll do some for dentures as well. And then any other state and or federal and state forms that are required. Specialty areas, these are things like, it's not on here. That would be things like where's your emergency supplies, your crash carts, where's your central supply, should you need to go get something, where's the activity room, what other, available things for either staff or for, residents and visitors, how to use the call light system, the paging system, how to, what happens when, somebody decides to wander out of the building, what's the process for that? And so data collection, this is one of the big things that we do as nurses, right? So weights, temperatures, right? Doing your assessment. When we look at weights, we're looking at an increase or a decrease of 5 to 10 pounds in 1 week. If I gain 10 pounds in a week, maybe I'm retaining fluid. Do I have congestive heart failure? What's my respiratory system sound like? Temperatures, when we look at anything over 100 degrees, especially in a residential area like long-term care, are they getting sick? We know in long-term care, one person gets sick and it's going through the whole facility, right? It's just spreads like wildfire. Upper respiratory, right? Is it just a runny nose, allergies? Lower respiratory, we're looking at any increasing shortness of breath or new onset of shortness of breath. Cardiac, we're looking at blood pressures. Are they having chest pain? Any edema, breast, any lump in breast tissue. With abdomen, we're looking at pain. We're also looking at increased girth. So retaining gas, are they having bowel movements? Do they have ascites, right? Do they have any liver issues? Musculoskeletal, you'll see this a lot in the elderly, right? Swollen joints, loss of strength, loss of motion, edema. Generally, we don't really worry a lot about reproductive system in long-term care. However, right, if they have any new onset of vaginal bleeding or any kind of discharge, that would be something to be concerned about. GU, right? Urgency, frequency, any blood in the urine, any excessive nighttime urination, any incontinence. With gentlemen, an enlarged prostate would cause, difficulty with initiating a stream of urine, dribbling, or, not being able to start or stop a stream of urine. Sleep and rest, doesn't matter if you're in long-term care or the hospital, we're going to wake you up to do stuff, whether it's giving medications or, taking vital signs. It's still making sure that we are providing an environment as conducive to rest as possible. Skin is a big one. Making sure that every resident has a skin assessment every week. Biggest thing that we worry about is those wonderful pressure areas that could develop. But we're also looking at any new bruises, any abrasions, any lacerations, rashes, other types of lesions. The procedure for your pressure areas is determined by the facility that you work at. Most of the time, as a nurse that is not working specifically in wound care, it's just providing oh my gosh, what is it? A size, measuring the size of the area and providing a description of the area. Do not stage the area. And then report off to the wound care nurse, or, whoever's in charge of that. Have to be careful. We don't want to stage inappropriately. Mobility and exercise. Everybody needs to get up and move as much as possible. Staying in bed is not good for anybody, regardless of whether they want to or not. Making sure that their hygiene status. My big thing in long-term care is oral care. I don't know why people don't like, well, I know why people don't like to do oral care, but it's really important to make sure that oral care is done, that they are clean, dry, that, they're moisturized. Um, and then how do they communicate? Are they verbal? Are they nonverbal? If they are nonverbal, what are we doing to provide a way for them to communicate? There's picture boards, there's all sorts of different communication boards out there that can be used. If they use sign language, there's interpreter services that can be utilized. Culture, religious, right? This is like their food preferences, their religious practices, their wellness, their illness beliefs. And then, of course, their psychological status, their level of consciousness. Are they, there's disorientation, attention span, vocabulary level, their memory, their affect. So when we, take all of that into consideration, these are some issues that we may have to deal with as a charge nurse in a long-term care facility. And so how many have, I'm going to stop sharing for a screen. We've all heard that leave it at the door, right? Leave your problems at the door when you go to work, right? Because it is not, right? You're there to perform your job. It is not the people that you work with or, that kind of, to deal with your personal issues outside of the facility, right? Um, and so it can be difficult when, people are bringing in problems from the outside as a leader, and you kind of have to find a way to work around it. It is not your job to counsel your CNAs or your other coworkers. It is not your responsibility to own the problem as well. But again, we do have to hold everybody to a standard to make sure that the patients and the residents are taken care of. They need to solve their own problems. If it needs to, then you can refer them up the chain of command, whether it's to the DON, to human resources. In some cases, there's like employee assistive programs that they can be referred to that may help them. Other things, when we look at working with nursing assistants, if they don't know how to do something that is within their scope or their job description, it is the responsibility of that CNA to figure it out. I know that sounds bad, but again, we have skills checkoffs that are done on a yearly basis. It is something that is taught to them. It is something that is within their job description. I am a firm believer in see one, do one, teach one. Okay. So if another nurse or a CNA, even with a student, if they don't know how to perform a skill, I'm going to show you how to perform that skill. So I will walk through the process. So I'll show you how to do it. So they're going to watch me do it. Then they're going to do it. All right. So then I'm going to watch them do it to make sure that they know how to perform that skill. And then they need to teach it to somebody else. All right. So see one, do one, teach one. That is the best way, even for us as nurses, to learn a new skill, because repetition is key, right? The more you do something, the more comfortable you get. And then it's like second nature. And just like nurses, lifelong learners, right? You're not going to just stop here. Even if you don't ever go back to school, you are going to learn every day. All right. You're going to learn something new. So just like with our CNAs, we need to encourage them to continue to learn, to reinforce their skills, to help them be better, right? Encourage them to go back to school, especially if you have some really great CNAs that you work with. Push them to go back to school to become nurses. And provide yours. I don't know who's my CNAs again. I know there's at least two of you. Who else is a CNA? Okay, so there's only a couple. CNAs can be your best friends or they can be your worst enemies. If you are mean and rude to your CNAs, then they are going to be the worst enemies to you. Then any CNA that I have worked with will tell you that I am right there beside them. I will do bed baths. I will change briefs. I will care for my residents. I don't need to, oh, let me call the CNA. No, like that is not how I play, because I learned very on as a brand new LPN that if you don't respect your CNAs, you're going to be in a world of hurt. Okay. But at the same time, if your CNA isn't doing what they need to do, you need to follow that up as well. So it should be a two-way street, and you should work side by side with your CNAs. I was never the one, I didn't bring snacks and I didn't do all that. My mom was that type of nurse, but I know that my CNAs knew that if it came down to a crunch, I was going to be right by their side, taking care of residents. So just making sure that you respect your CNAs, and that you don't just demand things from them. And then the biggest thing is, you know, working with the elderly is different than working with any other population. You know, they are getting older, they're declining, right? They're starting to lose their abilities. Um, and especially when, have your dementia patients. Dementia is hardest on the family. Okay. It's not hard on the resident. It's hardest on the family, because the resident doesn't know what they don't know, right? They don't know what they don't remember, but we know what they knew and what they don't remember. And so they're in their world, right? And so they don't, unless of course there's another disease process going on that's causing them pain or discomfort. But dementia is not painful. It just hurts the family. So it's really hard to deal with your family member getting dementia and having it progress, because, they want to remember them the way they were, right? And they don't, they may not recognize their family, their friends, even you every day you go to work, right? They're going to say, "What's your name again?" And that's just part of the dementia. So we need to build a really sincere relationship, not just with our residents, but with our residents' family members, because that is going to be the best way to work with them. Allow them to share their frustrations. We had a resident pass away. he was in hospice. But his brother is the one that came in, and his brother, and I had never met his brother before. And his brother, in the last 5 months, he buried the mother and his wife and now his brother. So like it's been a rough year for him. And so you could just see it on his face that, he had really probably just, starting to reach that breaking point. But these are some of the things that we are going to face, allowing them, to talk about their feelings and what's going on. If there's mistakes that were made with resident care, acknowledge those mistakes, apologize for the mistakes, and then, what are you going to do to make it better? But again, it's all about the open, the honest communication between you, the facility, and the families, and sometimes with the residents. Because you remember in long-term care, not every resident has dementia, right? Some of them may just have chronic disease processes that they're no longer able to stay at home and care for themselves, right? They have to have some sort of 24-hour care. And so that may be their choice, right? Is to be in a long-term care facility where their needs are met, but they still can maintain some autonomy, right? Within that realm, I guess. All right, so that finishes up chapter 17. Anybody have any questions? Did the test fry you? Everybody's
Yeah.
like, you guys are
But
not this quiet. like never.
by chance, are we gonna get our test grades any earlier this week, or we gotta wait all the way until like Friday or
So we have to
Saturday?
wait until all sections have tested.
Okay, so
And
we're
that's
looking at
why.
Friday again.
Yeah.
All right.
Can we at least
Right.
know the average?
Yeah, like, did we pass like blink once, blink twice, something?
Yeah, can I at least know what I got just this one time?
I'm just more curious about how many questions we had that were multiple choice. That scares me because y'all don't give half points or like some points for the multiple choice, and it was a lot of the select all the applied ones.
So I can already tell you there's a couple here that I'm gonna bring for review.